Good afternoon, and thank you for joining us for the first of the 21st webinars in the Women's and Pediatric webinar series. The topic of today's webinar is Maternal-Fetal Transference of Toxins, Call to Action, presented by Dr. Lyn Patrick. My name is Dr. Jessica Tran, and I will be moderating the webinar today along with Rachel Weaver. It is my pleasure to introduce Dr. Patrick. Dr. Patrick is also the Medical Director of Progressive Medical Education. She's a naturopathic doctor who graduated from Bastyr University in 1984 and has been in private practice for 27 years. She's now focusing on education and on progressive medical education. So with that, I'm going to turn it over to Dr. Patrick.
Thank you so much, Jessica. I'm very excited to be the presenter of this first webinar in this series. Dr. Tran and I have worked over the last year to put this series together, and we are very excited about our presenters. We have some really great information for you. So there are some handouts I want you to download, if you'd be so kind as to do that. There are some great articles. Excuse me, there's some great articles I've got for you. I want to call your attention to the slides. The Maternal-Fetal is the actual title of the slide presentation, so you can have a copy of the slides. And then there's some articles I'm going to be referring to in the middle. The Alt Med Review PDF is an article that Dr. Tran co-authored with Dr. Walter Krinian. It's a case study of maternal-fetal transference in Bartter syndrome, which actually turned out to be a case of mercury toxicity. So it's a very unique case study. Make sure that you get that. So let's go ahead and begin. I am going to go ahead and hide myself so that I can focus on the slide presentation. And I'm going to go ahead and start. All right, so my first slide is a mini review that you have. It's in your handouts pod. It's one of the handouts. It's an article that basically was authored by a group of researchers who are very involved in trying to create policy around the issue of fetal exposure to toxicants. And what this is basically, just for your education, is it's a review of the literature, but it's also a review of a conference that was held last year in Boston called the Prenatal Programming and Toxicity Conference. And this is actually the fourth one. They started in 2000. Or 2001, excuse me, 2010, not 2000. And they are conferences for researchers, clinicians, providers to gather and to discuss this issue that I'm going to present to you. It's called the theory of, and it's here, the acronym is DOHAND, the theory that disease can begin in the womb. So let's talk about that. The problem, as outlined by the Center for Disease Control, and you also have this CDC document in your handouts pod. This is a very, very crucial document because this is a report of the CDC and the ATSDR, which was published in the MMWR, Morbidity and Mortality World Report, the CDC publication, in, I believe, 2006. And basically what it does is it sets a precedent for doing preconception care, not just the kind of preconception care where you talk about smoking and folate, but the kind of preconception care that we're going to address in this course and in this webinar, where we actually talk about doing something about the problem in terms of toxicant exposure. So one of the things that we know is that the miscarriage rate is now 31%. The preterm birth rate is 12%. that is about 33% higher than it was 20 years ago. As you know, preterm birth has a significant risk to it. One of the main risks for preterm birth is low birth weight, and that's connected to not just severe physical and mental disabilities at term, but it's also connected to risk of death, not only during early childhood, but actually when the child reaches adulthood. And there's a higher risk of premature death from ages 19 to 36 years. So preterm birth rate is very serious. We also know that by the time children reach the age of 5, almost half of the children in this country will be found to suffer from chronic health conditions like not only the neurodegenerative conditions of ADD and ADHD, autism and bipolar disorder, but cancer, epilepsy, celiac, dyspraxia, food allergies. We know that cancer is the leading cause of death in younger children now. So what this all boils down to is that at the time that an American woman conceives, the probability that she will carry her baby to term, A, and that it will not suffer from chronic health conditions throughout his or her life, B, barely exceeds 1 in 3. So that means that an American female who is conceiving and trying to carry a baby to term has a little bit better than a 30% chance of being able to carry a healthy baby to term and have that child be a healthy child. So this is what one would consider a health emergency, and something needs to be done about it. We know that Generation RX, which is our children now are being called Generation RX, 1 in 13 of them will be diagnosed with food allergies, and we're talking about serious food allergies, not some sniffles, but cause of anaphylaxis. We know that between 1998 and 2008, and this is continuing to increase, emergency room admissions for anaphylaxis due to acute food allergic reactions have risen 265%. So this is a serious problem. It's manifesting as school systems not allowing children to bring food to school because of the severe risk for anaphylaxis for something as, well, commonly peanut allergies. It's one of the most common anaphylactic responses that we see. 10% of our children have asthma. 1 in 68 have been diagnosed with autism. If you split that by gender, it's much higher in male children, 1 in 55 according to the latest California Health Department research. Rates of autism have risen 30% in the last 2 years, so in the last 24 months. Significant rise, and that's not related to better reporting, actually. That has been documented to be an actual increase in incidence. We know that 30% of our children either have autism spectrum disorder, related neurodevelopmental problems, allergies, or asthma. So we're talking about 30% of our children, our pediatric population, being impaired. And if you look at the pediatric child health and wellness ratings for developed countries, we are 26 out of 29 developed countries. That's the United Nations and the World Health Organization that's done those ratings. So we need to change this slide because we don't want our future to look like this. And we believe that there is a solution. One of those potential solutions has been outlined by the President's Panel on Cancer. This is Margaret Kripke and Lysol Lethal, who are the 2 chairs of this panel. If you haven't read the President's Panel on Cancer, you absolutely need to download that and read it, because basically what the panel has concluded is that toxicants from our food, air, and water are the major cause of cancer in this country. They need to be strongly regulated. We need to reform TSCA. We're going to talk a little bit later on tonight about what TSCA is. And there's an edict here to the President of the United States directly to regulate the number of not just carcinogens in our environment, but chemicals that we know now are endocrine disruptors. We do not want this future for our children. And so that's going to take both for us as clinicians, it's going to take some education about what the alternatives are in terms of helping our parents clean up their kids' environment. And I'm talking about the indoor environment where most exposures still happen, but also some of the interventions that we can use. The reason I chose this slide is not only does it talk about the relationship between air pollution and respiratory disease, but it reminds me of a study that was done at Johns Hopkins where they used they've done a lot of research, for those of you that know this, with broccoli sprout extract, sulforaphane based compound, looking at its specific antioxidant activity, and they actually did a study with kids who had asthma, and they gave them sulforaphane extract and found that it significantly reduced the severity and the incidence of their asthma attacks. So there are things that we can do, but we absolutely need to address the toxicants that are in our environment. There is a consensus, getting back to the slide that I showed you about the conference looking at prenatal programming and toxicity. There is some pretty interesting evidence that just catching up with myself here, that exposure in utero specifically to metals, mercury, lead, cadmium, and arsenic, will bioconcentrate in the placenta. We're going to talk a little more about the actual, the kind of biochemistry and the physiology of the placenta, but that just the presence of these metals in the placental tissue can cause oxidative damage to neonatal brain tissue and can cause neurodevelopmental problems. We know that not only can that happen and have immediate effects, but particularly arsenic is the metal that the most research has been done on. Arsenic can actually cause alterations in gene expression in the fetal liver that can manifest, and now research is looking at specifically liver cancer in the 4th and 5th generation. So this in utero exposure is altering gene expression, specifically methylation, that may not manifest for 30, 40, or 50 years. The other thing we know is that these metals and other endocrine disruptors can alter estrogen signaling pathways. That can cause endocrine disruption, tumor formation. We're talking specifically about breast cancer. So exposure in utero is what we're going to concentrate on tonight, because this is a lecture about maternal-fetal transference. But know that the research is very clear that the effect of these exposures, particularly concentration in the placenta, can alter genetic signaling mechanisms that may not manifest for decades to come and can cause diverse problems, everything from cancer to diabetes to heart disease. So this all started, our knowledge and awareness of the fetal transference of toxicants started when the Environmental Working Group, in collaboration with Commonweal, which is an organization in California that works in the area of cancer and cancer support, and some scientists from Rachel's Network, named after Rachel Carson of Silent Spring fame, actually did a study with a small group of infants looking at cord blood. And, in utero, umbilical cord blood. Well, these were infants, they'd been born. So they were looking at the umbilical cord blood. There were 10 babies in 2004. What they found is that there were a total of 287 chemicals that were present in the cord blood. So these are chemicals that passed through the placental barrier, got into the cord blood, and went into the systemic circulation of the infants. Now, these chemicals, as you can imagine, wide variety of chemicals, everything from pesticides to polycyclic aromatic hydrocarbons, a lot of personal care product chemicals like phthalates, BPA, of course, metals. This was the first time really, because the EPA and the CDC had not really done a lot of good studies with cord blood, that we looked at the permeability of the placenta to all of these chemicals. This, of course, caused, I'm going to move forward here just a couple of slides to see if I can get to this. The American Academy of Pediatrics in 2011 came out with a statement saying, basically, we need to change our chemical management policy because it's failed. And it's really kind of interesting to know that what prompted the American Academy of Pediatrics to do this was this consumer health nonprofit environmental working group that got some funding to test these 10 babies because no one else had really done this research before to this degree, that had tested hundreds and hundreds of chemicals. So basically what the American Academy of Pediatrics said is we need to change the way that we regulate chemicals in the United States. And right now, what we are using is TSCA, the Toxic Substances Control Act, which was passed in 1976 and really not revised. And everyone, including Congress, the President's staff, admits, the President's staff in the area of the environment admits that this is really a piece of legislation that isn't working. And that's really what these prior slides are about, is that, we're looking at, even back in the early 80s, we knew that 78% of the chemicals that are high volume commercial use really haven't even had minimal toxicity testing. And that was in the 80s. 35 years later, nothing's really changed. So there's a big push right now to overhaul TSCA, and that really should be the TSCA, not the TOSCA. If you Google that, you'll get a lot of opera-related links, and nothing about the Toxic Substances Control Act. So I apologize for that. It's really TSCA. But Frank Lauterberg in the Congress has right now introduced an act called the Chemical Safety for the 21st Century Act. Frank Lautenberg, member of Congress, that is something that we want to support because it really does make TSCA, it really replaces TSCA and gives our regulating agencies some teeth so that we can actually regulate the worst chemicals in commerce. And those are what we call high production volume chemicals, the chemicals that we produce in over 1 million pound per year quantities. We've got a lot of them. There are about 3,000 of them. We have no toxicological information, as I just mentioned, for almost 80% of those chemicals. 716 of those chemicals are found in consumer products, and we're talking about things babies put in their teeth or their mouth, everything from personal care products like lipstick to teething toys. About half of them, we don't have any developmental toxicity screening data. So we really are not looking at basically the toxicity of the chemicals that are in commerce. And that's why they're getting into cord blood, is because they're out there, not just in our air, water, and food, but in our consumer products. So this is just another slide on those high-volume chemicals and the lack of testing. We haven't done neurotoxicity testing on the majority of those chemicals. We haven't done carcinogenicity testing on the majority of them, reproductive toxicity testing, et cetera, et cetera. So again, as a result of this obvious inability to regulate chemicals, unlike the European Union, which actually does a much better job than we do, the American Academy of Pediatrics has come out stating very clearly that it is of urgent necessity that we overhaul TSCA. So the other thing that's happened is that in January 2011, the NHANES study, which if you, let me see if I can find my pointer here. The NHANES study is the the National Health and Nutrition Education Study, that's done by the Center for Disease Control every 2 to 4 years. Now it's every 2 years. Looked at the number and the level of environmental chemicals in pregnant women in the U.S. for the year 2003 to 2004. This is available online if you want to take a look at it. What they concluded is that there is significant exposure to multiple chemicals that are unsafe at levels that are unsafe in a significant amount of pregnant women in the United States. And as a result of that, basically there has been a big push to improve the regulation of toxicants in the United States. We know that what these toxicants are, this is more information from the third national report based on the NHANES database, and this is all online for those of you that want to look at that under the Center for Disease Control. The Human Exposure to Chemicals database for the Center for Disease Control. This is from 2005. The majority of these toxicants are metals. We're talking about arsenic, cadmium, lead, mercury, and hexavalent chromium. Those are the top metals that people are most likely exposed to in the United States. 12% are polycyclic aromatic hydrocarbons from obviously grilled meat and air pollution, auto exhaust. 7% are dibenzo P-dioxins, which are a breakdown product from chlorinated compounds. Polychlorinated basically just means chlorinated compounds that can be anything from a pesticide or an herbicide to PCBs or other chlorinated compounds. Dibenzofurans, obviously flame retardants, PCBs were separated out here. I apologize from the other polychlorinated compounds. So PCBs were taken out of commerce in the 80s and are now mostly found in fish. Non-dioxin-like PCBs, those are just two different types of PCBs. Phthalates, plasticizers, phytoestrogens, mostly found in soy food, but they are considered chemicals because of their weak estrogenic effect. Organochlorine pesticides, organophosphate pesticides, and pyrethroid pesticides, which counter to popular opinion are not benign. Pyrethroid pesticides cause a lot of allergic sensitization, particularly in children. So that is what we're looking at as the body burden in pregnant women. So not only do we have a body burden, we have multiple environmental chemicals. And one of the things I'm going to talk a little bit about is what happens when you put more than one chemical in a biological system. We're starting to actually be able to research this using omics research, metabolomics, and nutrigenomics and toxigenomic research. So studies like this have been published on pregnant women. You can see here that this is again from the NHANES database, 1999 to 2004, that of a pregnant cohort, I think this was in North Carolina, 20% of them had detectable body burdens that were, well, below the limits of detection. So that was considered none. That doesn't mean they really had none. They were just below the limits of detection of the assays. 11% had only lead. About 10% had only mercury. About 6% had only PCBs, and then you can see the combinations of the metals and the PCBs here. And the largest segment of this pie chart is a combination of lead and total mercury and PCBs. Now, what does that mean in a pregnant woman's body when you have a combination of toxicants? Well, I'm going to skip this slide and come back to it. We know that, let me see if I can find this slide. there's been some new research, and I have to talk about this because it was published this month, 3rd of September 2015, from France, and I want to get to my notes so that I can tell you who did this work. So it was done at the Cancer Research Institute and Functional Genomics Institute at the University of Montpellier in France, and what they were actually able to do using genomics was to be able to actually prove something that we know as the cocktail effect. And what the cocktail effect really is, as you can imagine, is you put several things together and you get a much stronger effect than just a basic arithmetic effect. What these researchers did is they looked at two chemicals, transnonichlor, which is a metabolite of chlordane, and chlordane is a pesticide that has been taken out of commerce. I'm going to teach you about it in a little bit. And they added to that mix synthetic estrogen, so ethinyl estradiol, EE2, as it's referred to here in the diagram. And what they found is that if they took just transnonichlor, so a metabolite of a pesticide, or just ethinyl estradiol, component of oral contraceptive pill, and they threw it into a biological system, they didn't get a lot of activity. So PXR stands for basically a xenobiotic receptor. This is a receptor in the cell that actually picks up and carries a xenobiotic across the cell membrane or into systemic circulation. So not a lot of uptake, as you can see here, concentration and activity. But when you put them together, you get a massive increase in absorption and also in the activity of these two xenobiotics. So chlordane, as you can imagine, is a chlorinated pesticide. Most chlorinated pesticides have estrogen activity. You know, they act as an estrogen. They activate estrogen receptors specific to that particular pesticide. And what they found out is that when you have both of them together, they act synergistically and they sit in this little pocket of the xenobiotic receptors and are taken up much more efficiently than either one of them together. So this is really big. It's really big research because the model that's being used to prove this uptake is really very elegant and very tight. And what we're seeing here, you know, is a synergism that's quite concerning. So transnonichlor is a metabolite of chlordane. Chlordane was taken out of commerce, I believe, in 1988 because it was proven a carcinogen. Prior to that, there are about 30 million homes in the United States that were treated with chlordane as a termiticide, either chlordane or chlordane with heptachlor. Another termiticide, depending on the site of the home treatment. Indoor air levels of chlordane can still exceed what the EPA has noted as minimal risk level. Minimal risk level means the level above which there is significant risk for both cancer and chronic disease. So what we have is a situation where there's still exposure to chlordane, and we're talking about dust, that the chlordane is coming through the foundation of the home, either through outdoor dust or indoor air dust, and that we know that chlordane is taken up. That's excreted through the feces, through the urine, through breast milk in nursing mothers, and it also crosses the placenta. So this is a transplacental toxicant. So that's why this data was so important. I wanted to talk about it. So let's go back to more information here where I left off in terms of the kind of combination of things that moms are exposed to. So the sources here, there are a lot of them. We're talking about food, air, water, house dust. We get a lot of particulate matter coming off of couches, the main source of flame retardants. For humans, the main exposure is indoor air dust particles. So we also, one of the things that I will not talk about a lot tonight, we've talked about this quite a bit in our environmental medicine training course. We had one of the world authorities on electromagnetic frequency pollution, Dr. Magda Havas, do a class for us on EMF-related disease and sensitivity, but electromagnetic pollution is considered a prenatal toxicant. So we have to think about that in terms of preconception care as well. All right, so how many of us are exposed to these prenatal toxicants? Well, almost everybody. The Center for Disease Control says that basically multiple toxicants, even environmental tobacco smoke, metals like lead, mercury, phthalates, and bisphenol A, endocrine disruptors, perfluorinated compounds, and perchlorate, which are endocrine disruptors, are found in the majority of Americans. The majority of Americans also carry very specific toxicants that are known to cause neurodevelopmental damage in utero. So I'm going to talk about these specifically later on tonight. Mercury, PCBs. PCBs, again, were lubricants that were taken out of circulation in the 80s because they were known carcinogens. They bioconcentrate. They really biopersist. They don't fall apart very much, and they are found, the highest source of them now is in farmed Alaskan salmon, a food that really should not be eaten by anyone. It's not a food source, really. It's a source of mercury and PCBs, and there's a lot of work being done now to try and decrease the toxicant levels in farmed salmon. Excuse me, I said farmed Alaskan salmon. I meant farmed salmon. Farmed salmon mostly comes from areas other than Alaska. So perchlorate and pesticides. So the problem with these common chemicals, and this is a slide that John Chevrier, who I'm going to talk about a little bit later, he's doing a lot of this work. He's one of the main researchers in this area. And this is his slide, is that these chemicals, I'm talking about PCBs, flame retardants, bisphenol A, found in, not baby bottles anymore, but found in polycarbonate water bottles, linings of cans, dental sealants, thermal receipt paper, textiles, furniture, construction materials, electronic products, PCBs found in, formerly used as electrical insulation and plasticizers now found in farmed salmon, are lipophilic. What does that mean? Well, that means that they will be stored in the fat tissue of moms, females, they'll be stored in the fat tissue. So we're talking about breast tissue, adipose tissue. That tissue does go into circulation. These toxicants do go into circulation during pregnancy. The half-life of these toxicants is large. So for any of you that have been in our environmental medicine training programs, you know that the half-life of something in a biological system means that if you take that figure and you multiply it times 5 approximately, that's the rule, that's how long it will take to get that toxicant completely out of someone's system. So for PCBs, that could be up to 100 years. For a flame retardant, that could be up to 60 years. And for BPA, and I have to correct this slide because this is not an updated slide. We used to think that BPA had an extremely quick half-life in the body of 6 hours. So you stop being exposed to BPA, it's out of your system within a day and a half. maximum. What we found out now is that the science may not be correct on this. It may be that BPA lasts longer in the body, but we don't have the kind of half-lives that we have for flame retardants and polychlorinated biphenyl. So there is some evidence and some hope here that if we can get BPA out of these sources or teach moms to be, parents to be, and moms and dads how to avoid the common sources of BPA, which are canned food, dental sealants, and thermal receipts, that they may actually be able to decrease their body burden of BPA. So we had Dr. Fred Vomsal in our environmental medicine training program do a lecture on BPA. Very amazing researcher. He basically is the lead researcher in the United States on BPA and its effects as an endocrine disrupting agent. And basically what he says is that probably we have been using too high levels of BPA in our research, that it only takes about 1/20,000th of the amount of BPA that affects the uterus to affect the brain. So there's some talk among the researchers that have been doing BPA research that it's the lower levels of BPA, the very tiny micromolecular levels, that are actually causing the endocrine disruption. We'll talk about that later. So we get these, obviously, PBDEs, as I mentioned before, house dust, canned food, farm salmon. There is some PCBs in meat and cheese, but much, much lower levels than there are in farm salmon. So I'm going to talk about metals now. And the reason I have this up is because we really have done some good work. This is the EPA priority list in being able to identify what toxins we are most likely to be exposed to and which toxins are the most dangerous. So this is the priority list of hazardous substances. It's based on a point system, which is based on how much of it is laying around and how dangerous it is. So right at the top is arsenic. Beneath that is lead, mercury. Remember, I mentioned that these metals are the majority of the toxicants in terms of a class of toxicants in women's bodies, women of childbearing age. Cadmium is number 7. And then way down at the bottom here is hexavalent chromium. I know for those of you that have seen the movie Erin Brockovich, which starred Julia Roberts, you're familiar with some of the largest class action suit case studies that have ever been done, and 2 of them are for hexavalent chromium in Hinckley, California, and an adjoining town where the water was contaminated with hexavalent chromium. It's a serious problem in the United States. We have serious problems with our drinking water and hexavalent chromium contamination. So this is just to let you know that we're really looking a lot at metals here, and when we talk later on in the course about dealing with metals as a part of body burden in women, that metals really do have a huge bearing on a lot of disease states. Dr. Merritt and I are going to do a lecture on body burden of metals through the life cycle of women, starting with childhood, going into adolescence, and finishing with fertility and menopause, and really looking at how we can intervene in terms of metal toxicity in women and disease. So you've seen this slide before. This is about placental accumulation. We know now that there's very good evidence for the following diseases related to fetal origin, so meaning these toxicants coming through the placenta, being transmitted by the mom in utero. We have a serious problem with boys being born with hypospadia and cryptorchidism due to transplacental contamination of phthalates and BPA specifically. Here's the most evidence for those endocrine disruptors. Infertility and subfertility, Dr. Bonnie Nedrow, who's our resident expert on preconception care, is going to be doing a lecture on that in 2 weeks. ADHD and ASD and other neurodevelopmental problems, Parkinson's disease later on in life, and Alzheimer's disease. There's research showing that these are actually adult diseases of fetal origin, meaning that there are programming errors that are caused by toxicants in the womb that can lead to neurodegeneration later in life. Reproductive related problems like PCOS and endometriosis, we're going to have lectures on them by some experts in the area later on in the course. Premature menopause, this is a serious problem among young girls. Breast cancer and autoimmune disorders, we know that autoimmune disorders are an epidemic among women in the United States of America and are leading to not only disability but early death. Juvenile diabetes, obesity, excuse me, osteoporosis, thyroid disorders, and juvenile onset cancers. So the fetal origin of adult disease research is really exploding in these areas. How does this happen? Well, there are a variety of mechanisms. I'm not going to go into these in detail, but I want you to know basically what's being affected. So what's happening is that these endocrine disrupting chemicals, basically that's how they're working, is through the mechanism of endocrine disruptor alteration, is they are changing the way that not only our hormones work, but the cell receptors that accept signals and basically where these hormones dock on the surface of the cell. These hormone receptor sites are being altered. So the ability to make estrogen, androgen, and progesterone is being altered, and even the carriers in the blood, like albumin and retinoic acid receptor, which is incidentally the carrier in the blood that carries thyroid hormone to the fetus. These actual blood proteins are being altered by endocrine disruptors. So we're going to talk a lot about thyroid hormone for later on tonight. Receptors with no known ligand, meaning they're receptors that we're not even sure what hormones or what proteins dock on to those receptors. Those receptors are being basically they are being altered so that their ligands can't even dock, can't even attach to them. So we know that many of the chemicals that are found in human bodies and in cord blood act by interfering with these hormone receptors. Atrazine, which is found in a significant amount of drinking water, DDT, which is in the bodies of 99.9% of all Americans, vinclozolin, which is a very well-proven endocrine disruptor that's used on grapes as an fungicide. They all act by these mechanisms. So a lot of destruction of the way that hormones actually act in the developing fetus. And I went through the new research. We'll skip that. Methoxychlor is just it's similar to chlordane, so it would have the same effects when it's added to ethyl estradiol. It's in the drinking water of a lot of the country as a result of runoff, even though it was banned in 2003. And it's definitely an endocrine disruptor. It reduces sperm counts in all the animal models. And by the way, that effect is transmitted for at least 4 generations. We're going to talk about that, the transgenerational effect of some of these chemicals. So here's the placenta. We believed for a long time that the placenta-fetal barrier was a barrier. Basically what the placenta did was it allowed for the transmission of gases, oxygen, carbon dioxide, that allowed for the elimination of wastes, and that basically it was the way that the mom got nutrients to the developing fetus. we know now that the placenta is not really a barrier to most toxins. All the ones that I mentioned in the cord blood study, so certainly those over 200 toxins, specifically persistent organic pollutants like pesticides, PCBs, flame retardants, will pass from the umbilical cord to the fetus. The interesting thing that I think about the placenta is that the placenta actually differentiates based on sexual determination. So we know that the placenta is actually much more of a hormonal tissue than we thought it was. It's a hormonal basically an immune endocrine organ that produces hormones and growth factors that are very important in fetal growth, and that the placenta is itself actually altered by these toxicants that are concentrating in placental tissues and passing through the compromised placental fetal barrier. So the placenta is a very important regulator of fetal growth and may itself be being damaged by these toxicants. The placenta is vulnerable. The blood-brain barrier is vulnerable. We know that in fetal development and the first 6 months of postnatal life, that the blood-brain barrier is still developing, and there's some thinking now that it takes a couple of years for the blood-brain barrier to actually develop. I was at a conference where Martha Herbert, who is a pediatric neurologist from Harvard, was talking about the blood-brain barrier, and she was very clear that the blood-brain barrier is permeable even in adult life, specifically around the midbrain, that there is permeability of the blood-brain barrier, so it's never fully develops as a barrier, but it's certainly much more permeable in early life and in utero. The fetal liver is not fully developed, as we know, and is probably unable to detoxify all of these chemicals. You know, you really, phase 1 and phase 2, in addition to phase 3, are not very active in utero. The other problem in utero is that the embryo and the fetus, as you can imagine, as we know, have really high metabolic rates, right? They're undergoing rapid cell differentiation, tissue construction, development of organs, and this increases risk for genetic and epigenetic programming errors, which are one of the real problems in this adult development of fetally induced disease, right, is that you're getting a lot of methylation problems, both hypo and hypermethylation. So this is a very famous picture. This is a picture by William Eugene Smith, part of a couple of photographers who went to Minamata and documented the severe disaster in Minamata that was resulting from the contamination of the Bay of Minamata with high levels of mercury. Now this mom is bathing her 16-year-old daughter who was fetally poisoned. The mom ate fish during Minamata, gave birth to her daughter. The daughter never ate any fish because it was then discovered that the fish were poisoned. But this is probably, I think, one of our most compelling examples of maternal-fetal transference, right, is the transference of organic mercury into the brain and tissues of the fetus. So she was born blind, crippled, and as you can see, there's a lot of deformity as a result of her exposure to mercury. Now, what very few people know is that Lake St. Clair, which is part of the Great Lakes, was also contaminated with mercury in the 70s as a result of industrial contamination, and that in that period there was also something similar to Minamata Bay with the Native Americans that lived along the river there and along the lake. So not only do we recognize the exposure to the Japanese, which is still, it's being handed down through body burden, but it's actually happened in the United States of America. You can read about that in the great book, Diagnosis Mercury by Jane Hightower, who's an internist in San Francisco and has written a lot about mercury exposure in the United States. So, as I said before, there have been some really good studies looking at multiple exposure in women of childbearing age and risk factors related to those multiple exposures. I just showed you that pie chart is the study that I'm going to refer to now. One of the things that that study showed is that any fish consumption of these women was a significant risk factor for an increasing body burden. So they're not talking here about high mercury fish, they're talking about any fish consumption. The United States Forest Service did a study for 10 years trying to assess toxicant burden in inland fish in the United States. I've talked about this study in other lectures, and they found that 48% of inland fish are also contaminated with mercury and PCBs at levels higher than the EPA allows. So we may be looking at really rethinking fish consumption in preconception care. The other risk factor was heavy alcohol consumption. One of the things about heavy alcohol consumption is that alcohol, even though minimal alcohol consumption has shown to be beneficial in certain studies, certain epidemiological studies. One of the things that heavy alcohol consumption does is it eliminates, knocks out two enzymes in the body, catalase and superoxide dismutase, very, very necessary for the metabolism and elimination of mercury. So we have to think seriously about these two factors in our women of childbearing age and how we're going to intervene for preconception care based on their risk factors in terms of their body burden. And certainly the Center for Disease Control document that you have in the handouts pod states very clearly that we should actually measure all healthcare providers. It's there in black and white. All healthcare providers should assess risks of toxicant exposure. And my understanding as a healthcare provider is that assessment means not just asking people, if they spray pesticides in their yard, but actually assessing their body burden. So we'll continue this conversation as we go through this course. How are we actually going to assess and address body burden of toxicants in women, specifically women of childbearing age, and in couples when we're doing preconception care? Now, the other important thing about this study, and I'm leading into this study from that Minamata example of known toxicant exposure from fish. History of breastfeeding lowered the body burden. We know this in environmental medicine, that breastfeeding always lowers body burden. One of the most effective ways for women to lower their body burden is to breastfeed. Does that mean that women should not breastfeed? No, it doesn't. Breastfeeding is protective, and I'm going to go into some studies that show this clearly. Breastfeeding is protective against toxicants. But we also know that when a woman has a body burden and she does breastfeed, she will eliminate those toxicants in her breast milk. This is another reason that we're talking so much about preconception care in this course, and specifically in my lecture tonight, is we have to think about breast milk as a specific means of excretion of toxicants. And we, of course, want to lower body burden before breastfeeding. That's the caveat here. So, speaking of, this is a study published in Neurotoxicology in 2010. This is looking at prenatal exposure to methylmercury and PCB and stages of information processing in children born to Inuit moms who have high fish intake. So what the study shows is that prenatal methylmercury, which is the form found in fish, exposure in the womb here, this is prenatal methylmercury levels, and that exposure alters attentional mechanisms in the kids, modulating early processing of sensory information. So this is infant sensory information processing. By contrast, PCB exposure tends to affect information processing at later stages, meaning when the information is being consciously evaluated. So we're talking here early infancy, later infancy. But interestingly enough, these effects were mitigated in children who were breastfed for a more extended period. So for longer than, I think, 3 months was the cutoff in this particular study. So what that means is that there is a protective effect of breastfeeding. We know that breastfeeding alters and improves the health of the microbiome of the child. We know that microbiome can be important. There's very good studies showing this, some recent studies showing that microbiome can be important in assisting the elimination of metals. This is some great research that was done by Gregor Reed. I believe he did his research in Africa, where due to artisanal gold mining, many communities are being besieged with lead toxicity and mercury toxicity. This is a serious problem. So this is definitely good news that breastfeeding can be helpful. And this is really a study about how both methylmercury and PCB exposure in utero affect information processing. But I chose it because there's really some hope in this study that breastfeeding will mitigate to some degree these problems. In utero, exposure to DDT, DDE. DDE is the breakdown product of DDT. If you look in adipose sampling in Americans, we have much more DDE in our fat than we do DDT because we've broken it down. We had some lectures in the environmental medicine training group by a physician who's done some studies looking at the relative amounts of DDT and DDE in his cancer patients' fat tissue, showing that those who were unable to break down DDT were at much higher risk for recurrence of cancer and more complicated head and neck cancers. So we are carrying a body burden of DDT and DDE. So this was the relationship of those, the metabolite and the actual organochlorine insecticide and its relationship to neurodevelopment among young Mexican American children, and saying that we probably should weigh the risk-benefit ratio of DDT in eradicating malaria versus its negative associations with neurodevelopment. But again, breastfeeding was found to be beneficial among the women, even those who had high levels of exposure of DDT. So this is, again, one of the things we have to think about, the benefits of breastfeeding outweighing the risk of breastfeeding, but definitely the risk of DDT possibly outweighing the benefits of protection against malaria. So bisphenol A exposure during pregnancy can disrupt glucose homeostasis in the mothers and the adult male offspring. We know that BPA has a myriad of effects in animal models. BPA can reprogram skeletal muscle cells to turn into fat cells. So BPA is what's called an obesogen. It's also called a diobesogen, which means that it can cause diabetes, and this all happens in utero. There was nothing about breastfeeding here. This was an animal study. So in utero exposure to phthalates and duration of human pregnancy, there's some evidence here that phthalates can actually shorten the duration of pregnancy. We know that phthalates are endocrine disruptors par excellence. They can cause intersex situations in fish, and we can see this in studies where fish are exposed to phthalates. Prenatal exposure to flame retardants and neurodevelopment. This is a 2010 environmental health perspective study, neurodevelopmental effects in relation to cord blood. So we can actually measure cord blood flame retardant levels and predict neurodevelopmental damage based on cord blood levels. So there's a significant relationship there. So thyroid hormone. So I'm going to talk quite a bit about thyroid hormone in the next hour. Thyroid hormones, as we know, are crucial in pregnancy because thyroid hormone levels in mom determine brain development in the fetus. So thyroid hormones in pregnancy in relation to environmental exposure to organochlorine compounds and to mercury. What we see is that there's a negative relationship between the levels of PCBs and the pesticides that were tested here. Not so much mercury. Mercury has a different effect, but specifically the PCB congeners. I apologize, inorganic mercury. There is a relationship with inorganic mercury and total T3. So the higher the levels of these toxicants, the lower the level of total T3. That's relevant because both T4 and T3 have signaling effects in utero. So mom's levels of total T3 and mom's levels of total T4, and I'm going to add here reverse T3, have a very significant signaling effect on neurodevelopment. We always wonder about, reverse T3. Why do we have reverse T3? It's not just because of famine. It's because reverse T3 is very important as a messenger in neurodevelopment in utero. So we know that, and this is common knowledge, right, that risk factors for adverse outcomes in pregnancy include nutrient deficiency, specifically folate, alcohol and smoking, diabetes and obesity, drugs with high toxicity profile like diethylstilbestrol, but also hypothyroidism. Hypothyroidism, and specifically in these studies, hypothyroidism was linked to the presence of endocrine disrupting chemicals, can increase risk factor for adverse outcomes in pregnancy. So this is probably one of the areas that we really have to pay attention to is levels. We know that levels of maternal thyroid hormone are determined by a variety of factors, but body burden of endocrine disruptors is one of the main determinants of mom's level of both T3 and T4 as well as TSH. We know that the critical periods in human development, and here you can see from the very beginning of conception, period of development, so conception would be here, the implantation of the embryo, and then the beginning of the development of the central nervous system and the heart. Thyroid hormone starts affecting development of the cardiovascular system here. So the sensory organs, the eye, the ear, the nose, and the heart are all driven by thyroid hormone levels in mom. They are the main determinant of the fetal development of the sensory system. These windows of vulnerability can actually occur before conception, and that's why when we talk about preconception care, we're really talking about prior to conception, meaning we need to take a look at our infertile couples and also our couples who want to conceive, who may not be infertile, and talk to them about the time that's necessary to assess their body burden and to reduce their body burden, and that will be that they'll need to be out of danger long before conception takes place. Dr. Nedrow is going to talk about this in graphic detail. Her practice consists of a lot of preconception care. She's been doing it in groups for many, many years, and in her town of Ashland, Oregon. I think they put about 5,000 individuals and couples through their preconception care and detoxification programs. So before conception, this is a implantation picture of basically 1 week post-fertilization here, implantation of the blastocyst. We know that endocrine disruption and toxicant effects can occur as early as the gamete and certainly blastocyst stages. So it can happen really, really early. This is a critical windows of development chart from the endocrine disruption exchange, and I basically just wanted you to know about this. The endocrine disruption exchange is a group of scientists in my state of Colorado who have put together an amazing database that looks at I think a couple of hundred toxicants and specifically identifies where in the trimester these toxicants may act and how they may act. So you can see here on top, bisphenol A, dioxin, phthalate, and chlorpyrifos. You can actually click on these particular toxicants to see how they affect development. It's an amazing database. And the scientists at the Endocrine Disruption Exchange have spent many years looking at the effects of endocrine disruptors on in utero development. So it's a very, very amazing tool that we have access to. So what does endocrine disruption actually look like in terms of sexual disruption of sexual development? Well, we know that this class of chemicals called endocrine disruptors interfere not only with the production of hormones, but as I said before, with their transport, with their release, with their binding to certain both cell wall receptors and nuclear receptors, and the body's ability to metabolize and eliminate them. So every actual step in the utilization and the metabolism of a hormone that you can think of. And I'm talking specifically about thyroid hormone. I know more about thyroid than some of the sex hormones. But specifically for thyroid hormone, there's an interference with every single step of the way. So, you know, basically what we're talking about is interference with hormones in every step of sexual development. I want to talk about these pictures so that you can understand what's going on here. This is a genetic female with sexual development disorder, or development disorder of sexual development is actually how it's termed, DSD. So you can see here the masculinization or the virilization of the external genitalia. This is a genetic female. This is a genetic male with mixed gonadal dysgenesis, meaning, you know, the testicle here on the infant's left side didn't develop, and there may be some internal development as well, because this is an actual genetic XY, 46XY. Female. If I said male, I meant female. This is an actual female child. Here, this is a male, again, with actually, excuse me, this is a female. I'm getting my notes mixed up. This is a 46XY female, initially identified as a female, but found, excuse me, she was initially identified as a female, but she is genetically a male with hypospadia and undescended testes. That's why this looks more like female genitalia, but this is actually XY, 46 chromosome XY. And then this last picture is a, let me see here. This is a male with severe hypospadia, as you can see here, and bilaterally undescended testes and retained Müllerian structures. So these are kids who either will have some surgery or will be raised as intersex children, and very often they are raised as intersex children. This disorder, which we now know is related to exposure to everything from pesticides to endocrine disrupting chemicals like the chlorinated persistent organics, happens in about 1 in 2,000 kids, but that's underreported, highly underreported. So again, we talked about the mechanisms here. I'm going to skip this slide because it's kind of a repeat slide. One of the things that happens with endocrine disruption, and this does happen in the womb, is that these changes happen on a genetic level. This is an environmental health perspective study from Theo Colburn, written about endocrine disruption. We lost Theo this last year. She died after kind of a protracted battle with cadmium toxicity. She is definitely one of the most well-respected and well-schooled researchers in the area of endocrine disruption. She was actually one of the scientists that coined the term. This is a really good article I strongly suggest that you read. And basically, the caveat here is that if we had the kind of situation that we have now 4 generations ago, we would actually be having folks, both men and women who are unable to conceive happening now. So we're really looking at a situation that could happen as quickly as 4 generations from now, given the kind of ubiquitous exposure that we all have to these endocrine disrupting chemicals. So the thing about this situation is that we are still, unfortunately, acting on the kind of outdated understanding that the dose makes the poison. Right? We still see that written in toxicology texts. It's still quoted. I have to tell you, I live in Durango, Colorado, and for those of you that had been following the news, in the month of August, on the 5th of August, we had an environmental disaster that was probably, at least for the western United States, the biggest environmental disaster in a decade, where our water supply, the Animas River, turned fluorescent orange and became contaminated with 3 million gallons of mining wastes. Mostly heavy metals, maybe some radionuclides. It's too hard to tell at this point. But one of the things that that distressed me seriously is that one of the EPA scientists who was at one of the many town meetings said, well, the dose makes the poison, and there's more arsenic in our food supply than there is in the river water, which of course was an inaccurate statement in many respects. But one of the inaccuracies is that the dose makes the poison. Now that is probably true for arsenic, as you can imagine, but it is absolutely not true for the endocrine disrupting effect of many, many chemicals. And as Dr. Colburn has said, we're talking about infinitesimally small quantities of chemicals having the equivalent concentration of estrogen in our bodies. And to give you an analogy about how little it takes to alter the workings of the endocrine system, we're talking about 1/10 of a trillionth of a gram in the womb. That's equivalent to 1 second in 3,169 centuries. And this is a quote from Dr. Colburn. It's an analogy that I've heard her use several times about the infinitesimally small amounts of endocrine disruptors that it takes to disrupt the environment of the womb. We started understanding this really when we started looking at low birth weight babies and what was going on with low birth weight babies, and that they were much more at risk for cardiovascular disease in adulthood, and really trying to understand how could that be, that just having a low birth weight in the lowest quartile of birth weight and having low birth weight at 1 year could have a significantly higher mortality rate from cardiovascular disease than those who are in higher quartiles of birth weight, normal birth weight. So, of course, obviously, development of the heart, but even more so, having endocrine disruptors on board. One of the most difficult, at least difficult to not to understand, but difficult to make peace with problems is the disruption, the disruptive effect on the androgen receptor. And this is where, when we talk about boys being much more at risk for chemical trespass than girls, this is what we're talking about, is that the androgen receptor is the nuclear hormone receptor for testosterone and for dihydrotestosterone, and it's found all over the body. And yes, girls have androgen receptors as well, but as we know, the androgen receptor is crucial in the development of an embryo to turn into a fully formed male. You know, without it, all embryos turn into females. So, in fact, this is a lot of what's happening with a DSD phenomenon, disorder of sexual development, or disorder of sex development, those pictures of infant genitalia that I just showed you, is that we need the aromatization of testosterone, right, to estradiol for proper brain development. If we don't have enough testosterone to begin with, we don't have proper brain development. Testosterone fails to be produced in the male fetus, as it sometimes does with endocrine disruptors on board. You'll get a phenotypic female with testicles, and this is a very well-known phenotypic female, genetic male. Her name is Eden Atwood, and she is an activist to try and bring some attention to the phenomenon of androgen insensitivity syndrome, which we would call intersex syndrome, and that is that as a result of exposure to endocrine disruptors, the male fetus develops phenotypically as a female, as you can see here, but with testicles rather than ovaries, a uterus, and a vagina. So this, even though now the rate is 1 in 2,000, that rate is increasing significantly. There's some evidence to actually show that that's an outdated statistic, that it is more that it's that particular incidence could be up to 1% incidence rate now in certain populations. So what chemicals can cause this specific anti-androgenic effect? Most of them, as you can see here, are pesticides. Vinclozolin is actually a fungicide, but we're looking at chlorinated pesticides like DDT. These are all atrazine, linuron, prosimidone. They're all pesticides. Dieldrin and lindane. PCBs, a chlorinated persistent organic pollutant. Diethylstilbestrol, probably one of the most well-known and well-documented anti-androgens. Nonylphenol and octylphenol, these are chemicals that are added to dish detergent, laundry detergent, personal care products, bisphenol A, we talked about, methoxychlor, pesticide, and then the obvious medical drugs that are androgen receptor modulators. So the problem is that, you know, we do have evolutionary mechanisms to protect us against fetal estradiol. There's a protein called alpha-fetoprotein. Anyone who works in the field of obstetrics knows that blood levels of alpha-fetoprotein go up. They're produced by a developing fetus. In the liver, levels of alpha-fetoprotein go up with hepatocellular carcinoma. They're actually a marker for hepatocellular carcinoma. In the fetus, they have a very specific protective activity. The problem is that this specific protective mechanism doesn't work with xenoestrogen. So these chemicals that we're looking at here that are actually xenoestrogens and anti-androgens, the body can't protect itself against them because the mechanisms that are designed to do that, to protect the fetus against extra estrogen, can't work in the kind of the atmosphere of xenoestrogens. So we don't have any actual mechanisms for that. I want to talk a little bit now about metals as estrogen disruptors. When we look in the literature and when you talk to people about estrogen disruption or endocrine disruption, endocrine disruptors, they'll mostly say, well, you know, they're pesticides, herbicides, and persistent organic pollutants, the ones that we've been talking about. But I have heard several endocrinologists lecture on this, and we now know that cadmium is a xenoestrogen, that arsenic affects epigenetic androgen and estrogen signals, and nickel and chromium and methylmercury cause DNA damage and modify some of the genetic messengers that can actually cause endocrine disruption. There are lots of things that are epigenetic modifiers. Solvents will do that, TCE, trichloroacetic acid, air pollutants will do it, you know, the endocrine disruptors that we've been talking about. But I want to bring up this area of metals because it's overlooked. And I think it's really important to understand that metals have endocrine disrupting effects. We know that, again, detectable levels of these metals, specifically now we're talking about mercury, lead, arsenic, and cadmium, are found in up to 100% of cohorts of pregnant women in their third trimester. Now, when we're looking at metals as toxicants, we actually can assess for them pretty easily. Looking at blood metals, looking at urine levels of metals. These are spot tests, you know, where we're actually taking a blood sample or a spot urine sample. And what this particular study was looking at was, you know, what are we looking at as levels of concern? And that's why I bring up this study, is we can really look at levels of concern here. For cadmium, they're looking at the 95th percentile of NHANES. In the research, we sometimes look at lower than the 95th percentile, but they did find significant levels of pregnant women, even though it's only 1%. For that, you know, 2 in 211 pregnant women, you know, that's a significant number of women that had high cadmium blood levels. So that means acute exposure. For lead, they were looking at 4.4 microgram per liter, which is the 95th percentile. The 95th percentile, for those of you that aren't familiar with the NHANES database, means that that's the top 5% in terms of the highest levels of metals in that population. Those are the 5% of that population that have the highest levels. So in this population, 1.4% of these women had a level of 1.6 microgram per liter or higher, and that was a level of concern. For mercury, we actually have a lower level of concern. We have this level of concern, 3.5 microgram per liter, because that is the level at which the fetus and the cord blood are over the EPA allowable level. So the cord blood and the placenta bioconcentrate mercury, so the fetus actually has a higher level. So for lead, 3.5 microgram per liter was the level of concern there. And I think that you can, as a clinician, look at whole blood lead and look at the 95th percentile and say that's too high. From the research, we know that even over 2.0 microgram per liter increases risk for cardiovascular events, and I can see that my friend, Dr. Dorothy Merritt, who is an internist and our resident expert on this subject, is in the audience. Hi, Dr. Merritt. She and I are going to be teaching a whole webinar later on in the course on metals and women in the life cycle. I'm sure she would agree about lower levels of metal being of concern, lower levels of lead, excuse me, being of concern, particularly in women of childbearing age and basically pregnant women as well. We know that in pregnancy, bone levels of lead are brought into circulation, and a lot of times lead levels increase in pregnant women. So there were actually a couple women in this study that had acute arsenic exposure. They had blood levels of over 5.6 milligram per liter, indicating a significant problem. So we know that arsenic can be an acute problem, certainly in pregnancy. And that was probably from food and water exposure. So this is a problem, metals in prenatal exposure. 70% of that TEDx database that I showed you earlier on the windows of vulnerability showed that metals were a problem. And there were significant associations in terms of the levels of those metals and the effects of those metals in utero with cancer. So we're talking about blood-borne cancers, but also kidney cancer. The brain, the nervous system, the liver, the male reproductive system, and the eye also had high numbers of findings related to metals, as well as exposure and cancers of the lung and respiratory system and the adrenal system. So carcinogens in utero leading to, and of course these were animal models, but still leading to cancer later on. We know that arsenic has a huge effect on methylation, and we're going to have a couple of lectures in the course on methylation, both in the life cycle of women. We have an expert on methylation and oncology, and with kids and methylation as it results, or excuse me, as it pertains to pregnancy. Dr. Anju Usman is going to be speaking to us about that. So we know that arsenic modifies methylation. So even if you weren't born with single nucleotide polymorphisms, you can gain them in utero if you as a fetus are exposed to arsenic. Both histone modification and direct changes in gene expression. So histones turn genes on and off, and methylation of histones is one of the ways that that this transgenerational effect can occur. You know, once you alter histone modification, you can alter it for, as far as we know, up to 4 generations, but that's just because how long the research has gone on. So permanent changes in gene expression even after the arsenic is removed. So this is kind of a frightening phenomenon that if you have arsenic exposure on board during pregnancy, you find out and you remove that arsenic exposure, you can't undo the genetic damage that's been done in utero. We know that there is an increased risk of both lung cancer and liver cancer later on in life with prenatal arsenic exposure due to some of that genetic, epigenetic alteration. So mercury, we know that low-level mercury perinatally is linked to changes in the brain-derived neurotrophic factor gene. We know now that depression really is about BDNF. It's not about serotonin or dopamine or reuptake of serotonin. It's pretty clear that where depression comes from is alteration in the expression of brain-derived neurotropic factor. And this particular study looking at BDNF gene expression in mice showed clearly that perinatal low-level methylmercury exposure, so it doesn't have to be high, it can be related to dietary intake of methylmercury, can cause depression in later life. So we're not talking about a depressed fetus, we're talking about a depressed adolescent or a depressed adult. And then decreased genome-wide methylation levels have been found in polar bears as a result of environmental mercury exposure. One of the big problems now in polar bears is liver cancer as a result of mercury exposure from diet, specifically from sea life, you know, from seals and whales and fish. There's a lot of accumulation as you move further north on the globe, bioaccumulation of mercury in fish, and this is causing a significant increase in the incidence of liver cancer in polar bears. So lead, this is a fascinating study in women in Krakow. The study was done in Poland. They looked at levels of lead and mercury, but this research, the actual results were on lead in cord blood, and then in the children later on, and how the levels of lead in intrauterine exposure was very closely related to levels of, they use skin scratch testing, levels of allergic development to aeroallergens. So there were a bunch of aeroallergens they tested with skin scratch testing in these kids. And they found out that the ones who had blood levels just a little bit higher, and this is considered a safe level of lead in a child or an adult, 1.34 microgram per deciliter. But it was significant in the study that kids who had lower levels of cord blood as they developed as kids, were much less likely to develop allergies. So we have to think about lead in a little bit of a different light here based on the study. If there's more research that kind of supports this, I think we need to really think even more critically about what safe blood levels are in moms in terms of conception and risk. So what's published in the literature, and I cite this study very specifically, is that maternal levels of 5.0 microgram per deciliter or less are recommended. But as you can just see, according to the research I just showed you, that may not be low enough. I think that the maternal blood levels of 3.5 microgram per liter of mercury are helpful. The EPA says that 5.0 microgram per liter of mercury and above is an unsafe level in a pregnant woman or an adult or a child. But really, according to the research that these particular researchers published, because of the bioconcentration mechanism I alluded to before, if you have a mom who has a level of 5, we're talking about mercury now, not lead, 5, her kid's going to have a much higher level. So in order to compensate, the mom's level has to be 3.5 microgram per liter. So this is an often cited study for the actual application of preconception care in metals. I don't think that this level myself, I don't think it's low enough in terms of lead, given that prior study from Poland. So I talked a little bit about thyroid, and in the remaining half hour, I'm going to concentrate on this because it's so crucial. We know, as I showed you in the critical windows of development slide, that maternal thyroid levels are very critical in the development of the brain, the lungs, the heart, and the sensory organs very early on in the first few weeks of development. And again, it's T3 and T4 and reverse T3. Reverse T3, because of the delicate mechanism of neurodevelopment in a developing fetus, reverse T3 is used as a safeguard to protect against too much exposure to T4. So, we think of reverse T3 as kind of a villain, but it's actually an evolutionary mechanism for protection of the fetus in terms of protecting the fetus from excessive amounts of T3. So fetal thyroid becomes active, so the fetus itself starts producing thyroid as early as 12 weeks and is therefore dependent solely on mom's thyroid hormone for sensory organ development and cardiovascular system development and brain development. for the first 12 weeks of gestation. Iodine deficiency is really important here. In Africa, most of the research has come out of inland Africa. We know that overt iodine deficiency causes deafness and mental retardation because it results in hypothyroidism in both the mother and fetus. There are certain endocrine disruptors like perchlorate, which is a rocket fuel component, that can block iodine entering into the thyroid of the mom. And because of this, iodine deficiency becomes even more problematic. And we really need to make sure that our moms are iodine sufficient before they become pregnant. And certainly in pregnancy, iodine sufficiency is really crucial, really important. We used to think that the United States was a land devoid of iodine deficiency, but research published in Environmental Health Perspectives in the last 5 years, 6 years has shown that that's not the case, that we have a population of young women up to about 50% of whom may have iodine insufficiency. So it's a really critical problem here in America. So the standard reference range, we know during first trimester fetal development, even within the bottom half, or in the lower end of that reference range, can cause reduced IQ scores, impaired psychomotor development at 10 months of age. So again, that's related to the reference range of thyroid hormone of mom. And that can be influenced by iodine deficiency. It can also be influenced by some of the endocrine disruptors that I've mentioned so far. Things like PCBs, perchlorate, those are two of the most well-studied thyroid disruptors, but phthalates and flame retardants and mercury as well. So we know that in mom as well, iodine deficiency can lead to IQ problems as far away as 7 to 9 years after the child is born, and also can be related to problems with spasticity and ataxia, things that are really too seldom related to maternal iodine deficiency. And so I think when we're really thinking about endocrine disruption and preconception care, iodine has to be a top priority. So again, the thyroid gland is the sentinel organ for toxic exposure, and that's why we see so much autoimmune thyroid disease and so much hypothyroidism in this country, specifically in women more than men. And I think that's, the incidence of Hashimoto's is much higher in women, and I think that's because we have a different way of storing toxins than men do based on our hormonal differences. We know that high numbers of people have thyroid endocrine disruptors on board like BPA and like phthalates. This is actually an old statistic. Phthalates, I think it's in the high 90 percentiles of people who have phthalates in their urine. We know that phthalates are inversely related, meaning high levels of phthalates are related to lower levels of total T4, free T4, total T3, thyroglobulin, the ability to manufacture thyroglobulin, and positive relationships with TSH. So that means lots of phthalates on board, elevated levels of TSH. So this is particularly important in women of childbearing age. For some reason, that really hasn't been explained. In adolescence, there's a positive relationship with phthalates and total T3. So we get an opposite phenomenon. So phthalates drive total T3 up in adolescence, where they drive total T3 down in adulthood. And it's not very clear why that happens, actually. We know that in both humans and in animals, when we screen for BPA and phthalates, that there are a number of different ways that they can impact thyroid signaling. And we're talking about here at the level of the hypothalamus, the level of the pituitary, the level of the thyroid, the level of the cell. the level of the liver, how the body gets rid of thyroid hormone, and how effective it is at getting rid of thyroid hormone quickly. I see I have a couple of questions here that probably it's a good time to stop and take them since I've been missing them. I haven't been paying attention. I apologize for that. Can you talk a little bit more about BDNF and depression? You said it manifests in adolescence. Is that something we should measure, and what can we do about that clinically? I learned about BDNF from one of our faculty members who's a pharmacologist, and did a really good webinar on BDNF. And what he said basically is that it's not very clear what increases BDNF. There's some evidence that maybe melatonin will do that. Certainly, we can look at exposures. You know, he did mention that. The webinar was not specifically about toxicants, but that exposures may alter BDNF. He said it is a huge focus in pharma right now to find new antidepressants. I am not an expert in BDNF, so I feel like I'm not the right person to answer this question. But certainly, I think we can kind of, ask him. Okay. Isn't maternal blood levels of heavy metals still only a reflection of recent exposure, not reflective of total body burden? This is a very difficult question to answer, because we need to specify blood or urine. Urine levels and blood levels are specific for different metals. So for instance, let's talk about lead. Since I was on lead just a second ago, lead levels are reflective of body burden, and they tend to be reflective of body burden throughout the life cycle, so meaning in children as well as adults. That's not the case for cadmium, mercury, or arsenic. So that's a whole lecture that we'll do later on in the course. What screening tool do you prefer for determining iodine sufficiency? Excellent question. I wrote an article on this subject in Alternative Medicine Review, so if you just Google my name and iodine, it'll come up. It's full text. It's open access. I talk specifically about doing a 24-hour or a spot urine iodine. For that, there's several labs that will just do a spot urine or a 24-hour urine. Some of our integrative medical laboratories will do that. And I had a physician I was consulting with tell me that his local lab charged $250 for that test. That is highway robbery. That test should not cost more than $50 or $60. Okay, and then Deb Post is asking, how do you like to replace iodine? I use the form of iodine that is half and half. So it's half organic iodine, half molecular iodine, and it comes in about a 6.25 milligram. It's exactly actually 6.25 milligram capsule of iodine. So it's the kind of the molecular equivalent to the liquid iodine. All right, so it looks like I'm going to get another question here in a second. I can't talk about dosing because I think that dosing iodine is very specific to the severity of the iodine deficiency of the patient. And so we'll have to talk about that a little bit later when we get to that part in the course. But in some of my patients, I have needed to give them 6.25 milligrams on a daily basis until we got to iodine sufficiency, and then 6.25 milligrams per week. I am not of the Brownstein school of giving 50 milligrams of iodine per day. I think that's excessive. The problem is that we do have things like perchlorate on board that are thyroid disruptors and will prevent iodine from being absorbed into the thyroid and the breast cells. So we have to get those endocrine disruptors, those thyroid disruptors, out of the way, and that's a whole protocol for depuration and for lowering body burden that we'll talk about later. Okay, so the problem is that, as you can see from the ring structures of these endocrine, and I'm going to call them specifically thyroid disrupting chemicals. Because of the similarity, they can actually fit into some of the receptor sites that T4 specifically fits into, and mimic, like in xenoestrogen would mimic estrogen. These can be xenothyroid chemicals, so they can mimic thyroxine. But of course, they're certainly not going to turn on, well, in some cases they may. That adolescent phenomenon of having higher T3 levels with phthalates on board may be an upregulation, but in most cases they seem to downregulate the receptors. So even in a situation where you have adequate thyroxine, or T3 for that matter, there may be an interruption in the receptor mechanism where you can't turn the receptor on. So this is a little bit more about some of the research that we've seen. This is John Chevrier's slide from the Chamicos study, where they actually looked at first trimester, second trimester, third trimester, and delivery levels of exposure in the moms, and then they looked at TSH in blood spots in the infant after birth, and they found out that there was a relationship between neonatal TSH and levels of BPA in the urine, and PCBs in the blood, and PBDEs, flame retardants, in the blood of the mom. This is an amazing study. It's very large, looking at moms in Salinas, California, and the relationship of their exposure to endocrine disruptors and outcomes. And they're following the infants into childhood now. They have 6-year-old children that they're following in terms of their intellectual capability. They've actually been able to show that there is a relationship in this study between PCBs and neonatal TSH levels. This is the level in the moms of PCBs, and this is just another way of looking at the toxicity of PCBs and the levels of cytochromes that were metabolizing the PCBs and the levels of neonatal TSH. So you can see here the inducers, the PCBs, actually were related to upregulation of TSH in the neonates. So obviously abnormal thyroid functioning in the neonates. The other interesting research that I'll just end with tonight is someone who I very much respect and admire, Dr. Susan Nagel, who's an associate professor of obstetrics and gynecology at the University of Missouri. She specializes in looking at endocrine disruption. That is her specialty. That's her research area. She has very recently been looking at the effect of hormone receptor activities as altered by hydraulic fracturing chemicals in surface and groundwater. And she's actually published in this area. And here's a conversation, here's a podcast with her talking about her research. Excellent presentation, and some of the publications for her research. What she's looked at is the levels at which these endocrine disruptors act, as we talked about, parts per billion and parts per trillion, very, very close. She's looked at some of the effects that endocrine disruption can have on these hormones and these effects. And I'm going to go through this kind of quickly to get to the meat of this subject, this particular subject. She's looked at, and this particular map is a map of, let me get to that in my notes. I think these are the gas wells in California. There are 84,000 existing oil and gas wells in California. These are specifically the oil wells. So these are the gas wells, gas and oil wells in California. What she's found by looking at wastewater chemicals, and for any of you that have been following this in the news, they have found fracking chemicals in the drinking water in Southern California. These are some of the chemicals that she's researched and looked at for their endocrine disrupting effects. And these, you can see there's BPA in the fracking wastewater, as well as benzene and acrylamide, some specific toxicants. But what she's found is that there are thyroid disruptors in this fracking wastewater, specifically bisphenol A, of course, but naphthalene, nonylphenols, which we also find in personal care products, ethylene glycol, styrene. She's the first person to do this research and find that these water contaminants actually contain significant amounts of chemicals that act as thyroid disruptors. So very, very important research. So thyroid disruptors, now possibly water contaminants. So we know that these are found in other areas. In other words, we're exposed to these in other places, particularly ethoxylated nonylphenols, and they've long been called gender bender chemicals. They're in our cleaning agents, in our cosmetics, in our hair dyes. Ethylene glycol, we think of that as the main component of antifreeze. We know now that it is a thyroid disruptor. Styrene from styrofoam. 2-butoxyethanol, which is found in varnishes, caulks, and paints. So I would encourage you, just in our last few minutes, to read the Endocrine Society's white paper or scientific statement on this. It's a very good summary of the literature on endocrine disruption and disease. Talks about these thyroid disruptors and how they affect breast, prostate, brain, nervous system. And then, you know, we also have to think about other exposures in addition to these chemicals. We have to think about body scanners at airports, influenza vaccine, which is a source of mercury. Hair dyes, as I just talked about, have some contaminants in them. Caffeine is a known teratogen, and seafood, which is, as we know, as well as inland fish, a significant source of mercury from the literature. So we want to think about, of course, avoiding these things in pregnancy, but also preconception, right? Because these toxicants don't just act in pregnancy, they're going to act as part of the body burden in the mom's body preconception. And we are going to talk quite a bit in this course about assessment. You know, there are ways to assess preconception, there are ways to assess post-conception. So Dr. Usman is going to talk about actual assessment in autism spectrum disorder. We're going to talk about assessment in the life cycle. Dr. Winters is going to talk about methylation and assessment, particularly in women and reproductive cancers. And Dr. Nedro is going to talk more about assessment, particularly in preconception. So in terms of actually measuring these toxicants and protocols for depuration, we'll be talking much more about that as we go on tonight. So I just have a few more minutes. I want to make sure that if there are any last-minute questions, people get a chance to ask them. We do in this course have a community forum, so for those of you that are enrolled in the course, you have access to the community forum, which is a great place to look at questions, ask questions, see your questions answered. We have our faculty answer questions in the community forum, as well as Dr. Tran and myself go into the community forum at on a regular basis to make sure that everybody's questions get answered. So it looks like we don't have any more questions. So with that, I think that oh, there is one more question coming in. I think thank you. That was basically Darren saying thanks. I think, you know, in conclusion, what I want to say is that I want everyone here who is concerned about some of the things that I've talked about this evening to join us in this course. Dr. Tran and I and many of us in the environmental medicine community have come to the conclusion that we must learn and we must teach preconception care. It is really our only hope for turning this tide of really serious health catastrophes that we're seeing, in our kids, and as our kids are growing into adolescence now, we really need to turn this around. So I hope that you'll join us and become part of our community as we learn together, and as we join in the greater community of healthcare providers who are actively working to change policy in this area. For myself, as I go along in my kind of trajectory as a physician and learning more about environmental medicine, and particularly in the recent events in my town, I have come to the conclusion that I must become active in changing policy in this country. We absolutely need to do that. It is crucial. So with that, I'm going to turn it back over to Dr. Tran so she can have us look forward to what's coming up.
Thank you so much, Dr. Patrick. That was an amazing webinar. Well, since there are no more questions for tonight, please make sure you mark your calendars for the next session in the series on September 21st, Pacific Standard Time. We start at 5:30. We will be emailing everyone in the next week or so this recording, so you can review it at your convenience, and you will also receive a link to print your certificates, handouts, or if you have any other questions that come up when you review the webinar recording, you can submit it to Dr. Patrick. You can contribute to the community forum. And in the meantime, if you have any questions, please do not hesitate to email us at info@progressivemedicaleducation.com. And again, thank you so much, Dr. Patrick, for sharing your wealth of knowledge on this subject. It's always a pleasure to have you lecture for PME, and thank you to everyone tonight for joining us for this session, and have a great night.